Tokyolive,
Live.
Endoscopy 1.
Endoscopy 1.
Okay, so hello everyone. Welcome to the session of AI opens a new era of upper GI cancer diagnosis. This session is co-sponsored by AI Medical Service and Tokyolive Endoscopy 1. So I'm Haru Inoue from Digestive Diseases Center, Showa University Koto Taiyosu Hospital. It's my honor to co-chair this session with Professor Helmut Messmann. He is a professor at University of Augsburg and the former president of the ESGE. So, of course, he's a world-renowned endoscopist and also have a huge dedication, a huge experience of AI diagnosis, particularly for Barrett's esophagus. So, Helmut, would you give us some words?
Yes, Haru, first of all, thank you very much for the invitation to this wonderful Tokyolive meeting. I think this is an outstanding meeting, meanwhile well known all over the world and streamed to thousands of participants. And therefore, I'm honored to be part of this meeting and be part of this special session on AI in the upper GI tract. I think there is a future for AI in endoscopy. We do have data for the lower GI, but now I think a lot of people are interested what's coming up now for upper GI. And I think this session with outstanding experts in this field will show us what's going on with AI in the upper GI tract. And now let's start with our first presenters.
Okay, so it's my great honor to introduce Dr. Tomohiro Tada. So he graduated from Tokyo University School of Medicine, which is the finest academic university in Japan. He's an active endoscopist, actually performing upper GI and colonoscopy as well. He's organizing his own clinic, the Tada Tomohiro Clinic. And he is also well recognized as an entrepreneur, CEO of AI Medical Service, which he launched 5 years ago. So please welcome Dr. Tada.
Thank you for your introduction, Dr. Professor Inoue. Thank you also, thank you for your time. Here is the outline of today's talk. First, I would like to talk about the demand for endoscopic AI. Cancers of the digestive organs are the #1 cause of cancer deaths worldwide. In 2020, these cancers cause more than 20% of all cancer deaths. This Japanese data shows the difference in 5-year survival between cancer stages. As you can see, early detection of gastrointestinal cancer is essential to improve survival. Early diagnosis is even more important for upper digestive organs. Late-stage cancer of stomach and esophagus have very low survival rates. However, detecting upper GI cancer is very challenging. These 3 images are the stomach, and each contains gastric cancer, but it's difficult to tell where they are. The regions are here. According to some studies, up to 26% of upper GI cancers are missed during endoscopic examinations. Recent advances in technology and procedure may help. Deep learning technology means that AI can perform better than humans at image recognition. Big data has created large collection of expert diagnosis. More powerful computing means that we can now analyze all this clinical data. For these reasons, developing endoscopic AI is now possible. However, AI product for upper GI cancers, no upper GI cancer have regulatory approval in Japan. We are conducting research and development of AI for the upper GI. Now, I would like to show you some of the most interesting results from our work. To develop medical AI, the quality and quantity of teaching data is essential. After collecting the data, we must remove personal information, annotate images, and train the AI. Starting in Japan, we are working with more than 100 top-level institutions to develop high-performance AI. First, I would like to introduce our lesion detection system. In 2018, we reported on the use of AI in gastric cancer detection using still images. In this world-first paper, we reported 92% sensitivity for all regions. We also reported 98% sensitivity for regions above 6 millimeters in size. We tested the AI using movies as well. We reported 94% sensitivity in gastric cancer detection. The performance of the AI with movies was equivalent to still images. AI can detect gastric cancer even if background inflammation is present. This high performance of AI with movies shows that AI can be used in real clinical setting. In 2021, we compare the performance of AI to the performance of endoscopists. AI was much faster than endoscopists at lesion detection. Also, AI showed nearly double the sensitivity of endoscopists. As you can see, endoscopists show a wide range of performance at gastric cancer detection like this. The sensitivity of our AI exceeded some certificated endoscopists. We expect that using this AI will mean that all endoscopists can perform like experts. We also expect that using AI will raise the bar for endoscopic performance. In addition to gastric cancer, we also developed and reported on AI for ESCC. Once again, we compared AI to endoscopists. The AI showed higher sensitivity but lower specificity than endoscopists. However, when you combine AI and endoscopists together as a teammate, specificity stays high and the sensitivity increases. Now, I would like to talk about using AI to classify lesions. We reported on using AI to determine tumor invasion depth. AI classified lesions into two groups, lesions at M or SM1 and lesions at SM2 or deeper. Lesions at M or SM1 can be removed endoscopically. Lesions at SM2 or deeper require surgery. AI showed at least 94% accuracy for white light NBI and indigo staining. These results show that AI is not only good at detection, AI can also classify lesions and help make treatment decisions. Because AI shows a high level of performance, we can now use it in real clinical settings. Using AI in the real world is desirable for a few reasons. Today, endoscopists are overworked by diagnosis and treatment work. No matter what, cancer is often overlooked. In addition, big gaps in performance can be seen between experts and non-experts. Using Endoscopic AI will improve endoscopic medicine. AI is good for patients because it enables better diagnosis. And also, AI is good for doctors because it makes diagnosis and treatment easier. I would now like to introduce the first product we developed. Our product diagnoses gastric cancer lesions and is now under regulatory review. It shows doctors the target area's degree of similarity to neoplastic lesions. Our AI connects to endoscopic system using just a cable and can be used with any major endoscopic system. Our first product classifies gastric lesions into two main groups. The first group is early gastric cancer and adenoma. These are neoplastic lesions of the stomach. The AI will classify this first group as adenoma or adenocarcinoma. The second group is for all non-plastic lesions, like fundic polyp, hyperplastic polyp, erosions, or ulceration. The AI will classify normal mucosal or non-neoplastic lesions as low confidence. And certain imaging conditions must be met for our AI to function well. Poor imaging conditions like halation or blurring cannot be used with our AI. Furthermore, visual artifacts like blood and staining dye are also excluded from our first product. Have a look at the movie clip of a product demo.
これなんかはですね、これもなんかちょっと胃炎でね、胃が荒れてデコボコしてるだけなんじゃないかなと思うんですけれど、これはもう内視鏡検査中にすぐ AI 呼び出してきてですね、これはもうがんの疑いが高いので、ちょっと一生懸命検査しなきゃっていうことを内視鏡に教えて、本当に胃炎が胃が荒れてるだけみたいな、こういうのをがんであると、がんの疑い高いと教えてくれます。これなんかはですね、これはまあちょっとこれも荒れてデコボコしているように見えるんですけれど、これは良性の胃卵なので AI はローコンフィデンスがんではないと診断いたします。これなんかもですね、これもちょっとデコボコしてるんですけどね、胃炎でデコボコしてるのか、病変なのか微妙なんですけど、AI を出すとこれもがんであると、がんの疑い高いと正確に鑑別してくれます。最後ちょっと1個ぐらい。これもですね、そうですね、ちょっと胃が荒れてるだけかなと思われるかもしれないんですが、やはり AI だとですね、がんの疑いが高いと教えてくれて、このように早期のがんの見逃しを、この内視鏡 AI を使うことでですね、半減、究極的にはゼロにできると考えています。
We are now developing a system to detect gastric cancer as well as system for esophageal squamous cell carcinoma. We are based in Japan, the worldwide leader in endoscopic medicine, and Japan has more endoscopies per capita than other countries. In Japan, there are many diagnoses of gastric cancer. However, there are few cancer deaths. The difference between cases and deaths is due to due to our screening system and training program for gastric cancer. Using our AI, we want to share Japanese endoscopic abilities with the world. We are now working together with top-level healthcare centers to explore the use of Japanese AI outside of Japan. We plan to launch an office in Singapore in early 2023. We also recently opened an office in Silicon Valley. Our mission is to contribute to endoscopic medicine worldwide by using Japanese endoscopic AI. Before our founding AI medical service, my colleagues and I opened one of the top endoscopic clinics in Japan, performing 9,000 examinations per year in Japan. Together, we developed and introduced new colonoscopy techniques. We founded a medical service in 2017. Since then, we have been publishing lots of research. And this year, we will launch the world's first AI device for gastric cancer. In the future, we plan to launch a cloud platform that connects endoscopists worldwide. Now, for the summary of today's talk, endoscopic AI passed the stage of research and is now ready to be used in real clinical setting. The performance of endoscopic AI is high in certain tasks, but more advances will come. In the near future, AI will become an excellent teammate for endoscopists. And thank you for your time and attention.
So thank you so much, Tada Sensei. The congratulations is a very excellent results and really exciting presentation. We would like to have a discussion at the end of this session. So I'd like to introduce next speaker, Dr. Jimmy Saw. So he's a professor of National University of Singapore. And he's a professor of the Department of Surgery, and he also covers the therapeutic endoscopy, so various fields of gastroenterology. So very welcome, Jimmy Saw.
Thank you. Yeah, thank you, Professor. Allow me to share my screen.
Yes, of course.
Yes. First of all, we'd really like to thank Professor Inoue and also Dr. Tada for the kind invitation. It's my great honor for me to be in Tokyolive 2022. So my task today, we talk about is some of our new strategies for diagnosis of early gastric cancer. Yeah, this is the 3 topics I'm going to cover. Talk about the target screening for the high-risk patients. We will share with you our experience of using serum biomarker for gastric cancer diagnosis. And last, I will talk about some improving endoscopy with artificial intelligence. First, the topic on target screening for high-risk patients. This is the current gastric cancer screening strategy in the world. It's based on the incidence of a gastric cancer and also the country economies. For country with a high incidence of gastric cancer, and if they have a high resource, the national screening is the way to go, such as in countries like Japan and Korea. They have both high incidence and they also have the high resource. And for country, on the other hand, the country have a low incidence of gastric cancer and they have no resource, certainly we should focus on the symptomatic patients. But for the rest of the country, such as a country with a low incidence but with high resource, such as country in Europe or United States, North America, or in Singapore, then I think target screening for the high-risk patient is a more cost-effective approach for this issue. Few years ago, our group we wrote a review articles on molecular mechanisms of the famous Korea cascade of gastric carcinogenesis, looking at the change from the normal gastric epithelium all the way a stepwise progression to a gastric adenocarcinoma. In one of the pre-malignant condition called gastric intestinal metaplasia or GIM, is a very prevalent but a well-known pre-malignant conditions. Recently, there's a change of a recommendation for management of a GIM or gastric intestinal metaplasia, and both in Europe by the ESGE or in America by the AGA. So recently they recommend, both actually recommend against routine surveillance, but for patients with extensive IM, incomplete IM, or family history of a gastric cancer, they recommend 3 or 3 to 5 yearly endoscopy. However, and you look at the string of the recommendation or the level of evidence, the qualities are low. Hence, the clinical adoption of this recommendation in the world remain low because of this lack of supporting evidence. About more than a decade ago, we started this gastric cancer epidemiology program and tried to study this topic of screening for intestinal metaplasia in Singapore. This is a prospective, multi-center cohort of patients using endoscopic surveillance for gastric cancer, where we invited 3,000 high-risk subjects. These are Chinese in Singapore with 50 and above. These 3,000 patients underwent surveillance endoscope 3 times during the 5 years period. And they have standardized endoscopy protocol using the Sydney classification and also blood collection. And our endpoint of this cohort study is look at the incidence of early gastric neoplasia or EGN, which is a high-grade dysplasia adenocarcinoma. Just early this year, we just published the final result of our GSAP study, which is a prospective multi-center cohort study. So all our 3,000 subjects underwent an OGIM staging, looking at to stage the severity of IM based on the IM severity in the gastric body and also gastric antrum in the standardized protocol. In our study, we find that the age that adjusts early gastric cancer rate, in fact, is rise proportion to the OGIM stage. If a patient with no intestinal metaplasia or OGIM 1, the mild, that's baseline incidence. However, if you are OGIM 2, your incidence increased to 108.8 per 100,000 years. If you are severe IM, with the OGIM 3 and 4 stage, your incidence increased to 543.8 per 100,000. How about the timing of develop a baseline intestinal metaplasia to EGN? It also depends on the stage of the IM on baseline. For OGIM 2, it took average about 51 months to develop an early cancer in our cohort study. And for OGIM 3 and 4, you can actually change to a cancer within 2 years, about 23 months. Hence now our GSAP finding on the surveillance of gastric intestinal metaplasia show that actually standardized protocol using OGIM can enable a risk stratification. For every age patients, every average risk patients, these are mild OM patient, IM patient, actually they may not require surveillance. For people with OGIM 2, these are the people with intermediate risk, they should benefit from surveillance over 5 years. But for severe IM, those patients with OGIM 3 and 4, they would benefit from a more closer surveillance of every 2 years. Next topic I want to share about our use of a serum biomarker for gastric cancer. Our group are interested to look at the serum microRNA. As you know that currently there's no established serum biomarker for gastric cancer diagnosis. But serum microRNA is a promising cancer biomarker because most cancers secrete abnormal level of microRNA in the blood, and these microRNA are also stable in the circulation. Therefore, last year we published our results on our work on development and validation of a serum microRNA biomarker panel for detecting gastric cancer in a high-risk population in Singapore. We did a 3 phases study. The discovery and the verification phase, we used 330 cancers and 352 controls, and we generate a biomarker signature with a 12 microRNA biomarker panel that can differentiate gastric cancer from control. And we test this 12 microRNA biomarker panel used at a prospective validation phase. And this validation cohort is a prospective cohort. We recruited 4,500 subjects. Everyone underwent this serum microRNA analysis. About 1/3 of them have a positive result, and then about 2/3 is negative result. And all the 4,500 patients underwent a gastroscopy to identify the pathology. Like, look at it on the left, the patient with a positive result. There's 100 patients actually develop cancer with a rate about 6.7%. On the other hand, patient with a negative microRNA signature, only 15 patients develop cancer with a rate of 0.5%. The overall, the sensitivity of our microRNA serum panel is 87%, and the specificity is 68%. The positive predictive value is 6.7%, but the negative predictive value is 99.5%. And our serum microRNA actually can be sensitive through all the stage of cancer, from stage 1, about 88% to 92% for stage 4 disease. And the AUC of our panel is 0.85, and this is significantly better than the other serum biomarker commonly used for gastric cancer, such as pepsinogen, HP serology, CEA, and CA99. Then we also perform a cost-effective analysis comparing a screen population using this serum microRNA compared to the non-screen population. We find that using this serum biomarker, we can actually pick up more early stage cancer, and the cost of saving 1 query is $44,000, which actually reached the threshold of the WHO recommendation for screening. So our products, actually this panel has patented, and we call it as a GastroClear, and this is already commercially available because it's approved in both by the CE in Europe and also by the HSA in Singapore as a tool for gastric cancer screening. Finally, I just share some of the preliminary work of our group using improving endoscopy with artificial intelligence for gastric cancer. I think many of you know that a lot of work was done by the group, this AI company called AIM, and they developed a program called Tango. It's one of the first in the world to able to characterize or diagnose gastric cancer like this at the endoscopy. They can actually test for different types of early gastric cancer, and they, based on the AI algorithm, they can identify the risk of adenoma or adenocarcinoma. So far, all the paper on this AI system are from Japan. Therefore, our group actually bring this system and test it in our hospital in Singapore to validate the result. Just this year, we actually did the first study, first to look at the evaluation of the imaging and diagnosis, comparing endoscopies with the AI system, the Tango system. We looked at the still images of 300 patients, including about 22 of them are cancer or high-grade dysplasia. And they were comparing the accuracy and the sensitivity between the non-expert and the expert endoscopies with the AI. Although we don't see any difference between the three groups in these small size studies, but we saw a trend towards a better sensitivity for with the AI compared to endoscopies, especially for the patients for high-grade dysplasia. The sensitivity by the endoscopy is far lower compared to the AIM for the AI system. Hence, now we are doing a clinical prospective study of a Tango, and we plan and to start in this year. In summary, ladies and gentlemen, we find that the OGIM system is useful for as a risk stratification for patients with gastric intestinal metaplasia. And our prospective study recommend the high-risk patients, those are OGIM 3 and 4, should have a closer surveillance of every 2 years. And for the intermediate risk, those OGIM 2 can have an endoscope every 5 years as a screening. And we also identify a 12 serum microRNA bioassay can be used as a blood test as a cost-effective screening tool for gastric cancer. Lastly, we believe that artificial intelligence may improve the performance of our endoscopies to help to diagnose gastric cancer more accurately and early. With this, thank you so much for your question, for your attention, and I look forward to any comments or questions. Thank you.
So thank you very much, Jimmy. It's a great talk. And the Professor Fan, so you have a question to him?
Yeah, I think we're all looking for excellent screening tools, for any cancers. There's a lot of reluctance to using endoscopy as a screening tool because it's, it's invasive. I'm really intrigued by your miRNA panel, and I see that you're marketing it in Europe. But the testing that you did is basically in a Chinese population that lived in Singapore, correct? Did you also look at your data and look at samples throughout the world, or is your validation still only in the Chinese population within Singapore? And how do you expect that to translate worldwide?
Yeah, certainly. Yeah, thanks for the great questions. Yeah, we are very interested to test. So far, we have brought this signature to China and also to Japan. And we just completed the Japanese validation studies, and we are looking forward. We are talking to some centers in North America, and certainly we hope that actually we can try it out. I mean, certainly you're right. I mean, we need to really validate in the different population to see whether they are actually equally effective for patients with different ethnicity.
And this is more for the intestinal type as opposed to the diffuse type. Is that correct?
Yeah, good questions. Yes, yeah. Actually, that is for both, and for both, and the sensitivity is 88% for intestinal type. For diffuse type is 82%. It's a little bit less, and we are hoping that if we getting more samples, we can actually further improve, especially for the diffuse type of gastric cancer.
Fantastic.
Okay, thank you. So I'd like introduce the next speaker. So Dr. Jo-Ha Fan. So he is a professor of medicine, Stanford University. He is leading the division of gastroenterology and hepatology in Stanford University. Surprisingly, he's also a professor of surgery. Is that right? Two-way.
By courtesy, by transition. A lot of us endoscopists are becoming surgeons now.
Yeah. And then, so he's a director of GI endoscopic surgery. So Professor Fan, please start your lecture.
Thank you very much. It's a great pleasure to be here. And I think, thank you for the invitation. I've been asked to discuss the current status and future of gastric cancer screening in the United States. And I'll have to say that there's great opportunity for gastric cancer screening in the US because we're really not doing any of it yet. And I think that it has been unfortunately ignored largely in the United States. So what I'd like to do is discuss the demographics and disparities of gastric cancer in the United States, and then discuss what we're currently doing in terms of screening and surveillance in the US and what we really need to be doing. So as a comparison, this is a slide that compares esophageal cancer versus gastric cancer from our SEER database. And I have this not labeled, but if you just focus on the number of cases in 2021, you have 19,260 and then 26,000. If you were to ask many people, which they think is esophageal and which they think is gastric cancer, based on a lot of DDW presentations in the US, it's dominated by Barrett's esophagus and esophageal cancer. But what many people don't know is that there are more cases of gastric cancer than esophageal cancer in the United States. And it gets very, very little attention with similar late stage diagnosis and poor outcomes. So what the slide is intended to show is gastric cancer is not rare in the United States, although the perception is that it is rare. So we do have a problem of gastric cancer in the United States. The problem, though, is that it really impacts the minority population. So if you look at all the US population, the incidence is only about 10 per 100,000. And for white people, it's only 8.9 per 100,000. For African Americans, it essentially doubles to 14. If you aggregate all Asians and Pacific Islanders together, it's actually still pretty low at 14.3. But then if you start disaggregating this and look at both Japanese Americans and Korean Americans, the incidence actually becomes almost equivalent to colon cancer. So what this shows is that by disaggregating and looking at Japanese, Koreans, actually Chinese and Vietnamese, we know that there is a very high-risk population in the US that probably warrants screening and surveillance. Unfortunately, in the United States, most data is only aggregated by Asian and Hispanics. They're not disaggregated by specific, more specific ethnicities. However, in the state of California, we actually have been collecting data by more specific ethnicities. And what this shows is that the Koreans in particular have a 13-fold increased risk of developing gastric cancer than non-Hispanic whites. So non-Hispanic whites are the reference. Vietnamese have a 6.5 times more likelihood of getting gastric cancer. Southeast Asians are over 5, Japanese are over 5, Chinese are almost 5, Hispanic. So if you look at this, the risk is mainly in East Asians and then also in Hispanics. But not so much in the South Asians. So you can see why if we aggregate all Asians together, we dilute this number down. So there are clearly high-risk groups in the United States that are being ignored. This slide shows the gastric cancer incidence or the overall cancer incidence and compares them to Koreans. And I just want to show some lines for reference. So this green line is the US colorectal cancer incidence. And so we've determined that colon cancer is worthwhile screening, and we actually recommend colon cancer screening beginning at the age of 45 now. So we're looking at somewhere in the, the 35 to 40 per 100,000 incidence rate. If you look at Koreans in Korea, their risk of stomach cancer and colon cancer are actually pretty similar. And they're well above the US rates for screening. But the blue line is the US gastric cancer rate. And this is what is very low. And this is the overall perception in the United States, is that gastric cancer is not a problem. But the issue is that if you look at like immigrants from Korea, they follow the Korean line. And we know that people who recently immigrated to the US from East Asia, they typically follow the incidence based on where they came from. And we've been ignoring this population in the US, unfortunately. So I get asked a lot, well, is screening effective? And this audience obviously knows, especially in Japan, obviously screening is effective, and that's why you do it. If we look at both South Korea and Japan, who have screening programs, the 5-year overall survival for gastric cancer is 67 and 60% respectively. In the United States and in Western Europe, where we don't have any organized screening program, our gastric cancer survival rate overall is a dismal 27 and 25%. and it parallels the percentage of gastric cancers diagnosed at a localized stage. So South Korea and Japan are diagnosing high rates of early gastric cancer, whereas in the West, we're diagnosing almost no early gastric cancer. And the early gastric cancer that we detect is usually just opportunistic. They're getting, it's not from screening, it's from endoscopies that are being performed for other reasons. So there is great opportunity to increase these numbers. And also, again, is screening effective? Japan has been screening for decades. South Korea has recently established screening programs. And so you can see as their screening program has developed, their percentage of early gastric diagnosis continues to increase. And this is likely due to more patients coming in, better experience at looking for these lesions. In the US, where we've done nothing, the percentage of early gastric cancer diagnosis has remained flat for multiple decades, and will unlikely change unless we do something differently. And again, another comparison that shows the same thing, the overall survival. I think this is what's the most unfortunate part of this in the United States, is that our 5-year overall survival for gastric cancer is only in the 30% range, whereas Korea and Japan are well over 60%. And so this really shows that the US needs to do something. And what's the main difference is the US has no screening program, and both South Korea and Japan have established screening programs. The ASGE actually has guidelines that say that they suggest EGD for gastric cancer screening in new US immigrants from high-risk regions around the world, such as Korea, Japan, China, Russia, and South America. Basically, if you look at this heat map, anywhere that's red, these patients should be considered for screening, especially if there's a family history of gastric cancer in a first-degree relative. Because again, you know, the US is often very US centric, but stomach cancer, if you look at it, you know, worldwide, is a third leading cause of death, third leading cause of cancer death worldwide, even though it's around 17th in the United States. But there are populations within the United States, because it's such a heterogeneous population in the US, that are at very high risk, and we're ignoring these populations. You know, why can we screen? And I don't need to tell this audience this, but, you know, the reason we can screen is because there's a progression to gastric cancer, at least for the intestinal type. So it goes through a precancerous, you know, we have inflammation, H. pylori, that then develops into these precancerous lesions, such as intestinal metaplasia and then dysplasia. So we can screen for those, and then we can hopefully identify early gastric cancers. So there's a cascade that we can follow that can be both screened for and surveyed for. We did, this is an analysis that I did when I was at the University of Washington, where we looked at all the patients who developed gastric cancer in the University of Washington system. And the odds ratio for gastric cancer, for developing gastric cancer, if you had intestinal metaplasia, you had a 9 times increased risk of developing gastric cancer. If you were actually East Asian in the University of Washington system, you had a very high risk of developing gastric cancer compared to just other Asians. If you aggregated all the Asians, it was only a 2-fold risk. Also, tobacco use, family history, and H. pylori had increased risk, but not as significant. So it really had to do with intestinal metaplasia and coming from East Asia. So in terms of, this is what's really controversial, is the management of intestinal metaplasia. I think that, you know, in Asia, it's very well known, the risk of intestinal metaplasia progressing on to cancer, and you don't need to biopsy for that. You guys do very excellent endoscopic evaluation. Unfortunately, in the US, we don't do that. And so the ASGE had guidelines suggesting surveillance in patients with intestinal metaplasia who are at increased risk of gastric cancer due to ethnic background or family history. But it's actually very controversial on how do you do the surveillance, how often do you do the surveillance. But I think that, you know, for those who are in Asia and are experiencing this, it's obvious that intestinal metaplasia require some form of surveillance. It's similar to Barrett's esophagus. There's parallels with Barrett's esophagus, intestinal metaplasia, and progression onto cancer. However, in the U.S., the guidelines are very, very weak when it comes to surveillance of gastric intestinal metaplasia. The AGA last year just came out with recommendations on intestinal metaplasia, and they actually suggested against the routine use of endoscopic surveillance in intestinal metaplasia. And this was highly controversial. And this was because they actually ignored a lot of the data out of Japan on surveillance, because the Japanese in general don't biopsy. So there's no documentation of intestinal metaplasia in these patients that then go on to dysplasia. So we did respond to their initial release, and we asked them to at least clarify, and they did add a comment that said that patients with intestinal metaplasia who are at higher risk for gastric cancer, who put a high value on potential but uncertain reduction in gastric cancer mortality, and put a low value on the potential risk of surveillance, could reasonably elect for surveillance. So I think this is controversial. I think that if you're in a high-risk group and you have intestinal metaplasia, I think that there's plenty of data that suggests that these patients should go on for screening. In the US, we are not great at endoscopic, just pure endoscopic surveillance. So we do biopsies, and the most traditional biopsies we do are the Sydney protocol, which were really designed to detect H. pylori. So typically we'll take biopsies from the antrum, incisura, and then the body, as well as targeted lesions. And I just want to conclude with this last slide in terms of cost effectiveness. Shalda Shah and her group did a cost effectiveness analysis using a Markov model, where they looked at doing an endoscopy at the time that patients presented for their screening colonoscopy. And basically, she showed that if we follow this algorithm, that this is cost effective for everybody except for non-Hispanic whites. So if you're Asian, Hispanic, or non-Hispanic Black, this is actually cost effective in terms of reducing the costs associated with gastric cancer. So there is cost effectiveness data. I think that the US has a lot of catching up to do. Who's at risk? Well, in the United States, we're a melting pot. We're a very heterogeneous group, and we have immigrants from all over the world. And what I would say is, if you are a first generation immigrant from a high-risk region, you should really be thinking of getting screened, especially from Korea or Japan, where there are clear-cut screening guidelines and data to back this up. So where do we go next? I mean, we're really trying to advocate for establishment of guidelines in the United States for high-risk populations to attempt to increase the rate of early detection of gastric cancer. It's catching momentum because people want to do ESD in the United States, and the only way you're going to do gastric ESD is if you screen for gastric cancer. So hopefully we'll make progress. Hopefully our numbers will improve over time, but it certainly is an uphill battle. So our take-home points: high-risk populations in the US, East Asians, Hispanics, and patients with family history likely warrant screening. We know that intestinal metaplasia is a pre-malignant condition, and this should be surveyed, especially in high-risk groups. We're lacking guidelines for gastric cancer screening. We need them. And high-grade dysplasia and early gastric cancer can be easily managed endoscopically without the need for surgery. And we need to improve outcomes in gastric cancer in the United States. And the only way to do that is either prevention and/or early detection with screening. So I thank you for this opportunity, and it's been my pleasure to present this data. Thank you.
Sir, thank you very much, Professor Fan, and a great talk. I really surprised the number of advanced gastric cancer is a higher incidence of Barrett's esophagus when I joined the DDW. So I feel that most of the cancer in the United States is dominantly Barrett esophageal cancer. So it's a big surprise for me. But of course, our population is East Asian American. But it's a very impressive talk. Thank you so much.
Yeah, absolutely.
So, yeah, we will discuss later. So Dr. Helmut Messmann, please introduce the next speaker.
So now it's a great honor to introduce one of my co-workers, which is Dr. Alana Ebigbo. Dr. Ebigbo is in my unit since 2004, and he started his career as a fellow and is actually he's an infectiologist. But then he made a transfer to a transmission to gastroenterology, and now he is an outstanding expert and one of the rising stars in Germany on interventional endoscopy. He was trained in Japan by Dr. Yahagi and Dr. Oyama. He is outstanding now in doing ESD in Germany. So and he has a lot of experience in diagnosis and treatment of early GI neoplasia with different technologies like ESD, EMR, underwater EMR, or full thickness resection. And he has also gained some experience now in third space endoscopy. His research field is AI. He has a lot of experience with Barrett's esophagus. And in our unit, we do have the most Barrett cancer patient population treated with ESD in Europe. And though we have a lot of data, and he developed in our team together with colleagues in Regensburg, AI system, which is now presented by him and Dr. Ebigbo. We are now happy that you present your data and your experience on AI and Barrett's esophagus. Please.
Thank you very much, Professor Messmann, for the kind introduction. Thank you, Professor Inoue and AI Medical, for the invitation to speak here today. I'm going to talk about the clinical use of AI in Barrett's esophagus. And in Augsburg, we have been doing a lot of work on not just testing AI in Barrett's esophagus, but also developing AI, both from a clinical point of view, but also working together with a group of computer scientists. So we are moving now from the stomach to the esophagus. And as we all know, the esophageal adenocarcinoma is a growing problem in Europe, especially. The missed rate for esophageal adenocarcinoma is about 6.4%. There is a higher risk for missing esophageal adenocarcinoma, especially early esophageal adenocarcinoma, when non-experienced endoscopists are involved. But also small lesions or flat or depressed lesions are often missed during routine endoscopic examinations. Barrett's esophagus is a major risk factor for esophageal adenocarcinoma. And we know that Barrett's esophagus is a challenge. This is a patient that was sent to us with 3 biopsies, targeted biopsies of these 3 sections of Barrett's mucosa. And you agree with me in the next images that this area was the culprit lesion. This is the expert evaluation using acetic acid chromoendoscopy, indigo carmine chromoendoscopy, as well as virtual chromoendoscopy with MBI. And with this expert evaluation, you can then agree with me that this is the culprit lesion. However, this is a difficult task, especially for endoscopists not usually involved in Barrett's diagnosis and treatment. So to improve the detection and characterization of Barrett's dysplasia and early Barrett's adenocarcinoma, we feel that artificial intelligence can and should play an important role. AI assistance in the upper GI tract is there are multiple possibilities of applying AI, but I want to talk in particular about detection and characterization. We already know that there are 2 CE certified devices for detection of Barrett's neoplasia, the WISE Vision system by NEC Corporation, and the CADU system by Odin Vision. In Augsburg, we have developed an AI system and have also published our results multiple times. And I would like to show you some videos and present to you how this AI system works. So this is a patient with a long Barrett's segment, maybe C4M6, according to the Prague classification. And what you can see here is the user interface in the detection mode. In the detection mode, the endoscopist scans the Barrett's mucosa, and then the AI system highlights with a yellowish color suspicious areas. When the endoscopist notices this area, he can now go into the characterization mode and go close up, either in white light, TXI, or in NBI mode. And then the AI system also generates, in the top left corner, a heat map. This heat map produces a color-coded characterization showing reddish areas as dysplastic or neoplastic. A second example I'd like to show here is a case of a patient who had undergone ESD for early Barrett's cancer and had come for surveillance to our unit. And as you know, such patients can develop metachronous lesions. And here you can see a very tiny area, quite difficult to detect. And in the detection mode, the AI system had already highlighted this area. Now, when the endoscopist goes close up, you can even see underwater the nice delineation and characterization, also again using the heat map code. The system, and this was important for us clinicians while developing it, should work both in white light and in virtual chromoendoscopic modes. And this is what I'd like to show you here. You can see a very tiny island of dysplasia. This area was a high-grade dysplasia after endoscopic resection. And the system nicely picks it up and also characterizes it again using this heat map color coding, both in white light, in TXI, as well as in NBI modes. We wanted to understand what the influence of AI on the diagnostic performance of non-experts in Barrett's esophagus-related neoplasia is. We are currently working on two studies, clinical studies, but this is a pilot study which we did on diagnostic videos of Barrett's esophagus and presented at the ESGE days. We showed 12 diagnostic videos of Barrett's esophagus or Barrett's esophagus-related neoplasia to 3 non-experts and to 3 experts. And in a kind of a tandem trial, we asked the non-experts first, as well as the experts, to assess without AI support, and then to assess again with the support of AI. And as you can see here, even though it's a pilot study on a few number of videos, you can already see the tendency that non-experts have a poorer assessment and detection of Barrett's neoplasia as compared with Barrett's experts. But with the support of AI, this their accuracy increases dramatically and even increases better than those of expert endoscopists. A second question which we are asking ourselves in Augsburg is, how can we distinguish between T1A and T1B cancers in Barrett's esophagus? Because this could have also a therapeutic implication. And we tried to distinguish using endoscopic still images. We created an algorithm and then tested the algorithm and also compared the performance of the algorithm to expert endoscopists. And as you can see here, even though this is work in progress, the AI-based accuracy was similar to that of expert endoscopists in the differentiation between T1A and T1B. And this is quite a difficult task, as you will agree with me. Finally, I would like to show you one important aspect, because I'm talking as a clinician here. I want to show you an important aspect of AI-aided examinations, which is an aspect called optical flow. Now, you all know that during an examination using AI, there is an interaction between the AI system and the endoscopists. Usually, the AI system makes use of the images and the video frames presented to the endoscopists, presented by the endoscopists irrespective of how high of quality these images may be. So we created an optical flow, which is a method of locating and quantifying motion between consecutive frames. And what we are trying to show is that optical flow has the potential to improve human-computer interaction by hinting the endoscopists on the quality of data being presented to the AI system in real time. So I'd like to summarize. I have been able to show you that AI in Barrett esophagus can be used especially for detection and characterization of lesions. We have seen a number of CE certified systems in Europe. In Augsburg, we hope to introduce our system very soon. We have shown that our system has a high sensitivity and specificity in the detection and characterization of especially early lesions. And these are the early lesions we need to improve the outcome of esophageal adenocarcinoma. We think that AI should serve as a clinical decision support tool, especially for the non-Barrett expert endoscopists. And we also think that there should be a way of showing the endoscopists in real time what the quality of the human AI interaction is at the user interface. So thank you for your kind attention, and I'm happy to discuss some questions with you. Thank you.
So Dr. Bigbo, thank you very much for this exciting lecture. You showed the system is really fantastic, and I think in the future we will really have some other interesting tools on upper GI, especially for Barrett cancer detection, differentiation, and also staging, as you showed. And this is for sure a big advantage which we can expect not only for Barrett but also for gastric cancer. So thank you once again for this wonderful presentation. So now it's my great pleasure to introduce Professor Pratik Sharma, a good friend of mine. He's an outstanding expert, and I feel like introducing the Pope of endoscopy. Professor Sharma is well known as an expert in the field of Barrett's esophagus. He published recently the Bing classification, and I was honored to be part of his team. But he's also an outstanding expert on GI diseases and cancer, especially focused on advanced imaging, endoscopic treatments. Professor Sharma completed his internal medicine residency at the Medical College Wisconsin in Milwaukee and his gastroenterology fellowship at the University of Arizona in Tucson. His opinion is quite important, as we know, and he gave also interviews to the Wall Street Journal and the Newsweek, which is not usual for our doctors. He has several thousands or hundreds of publications, so he is really well known although in our society, and publishing in high-ranked journals like New England Journal, Annals of Internal Medicine, and so on. Recently, Dr. Sharma has been the task force leader of the first global AI-GI endoscopy summit, and I think he is for sure one of the leading persons on AI topic in the world. And now it's my pleasure, Pratik, you give now your lecture on AI endoscopy and your personal view. Pratik, we are happy to have you here and welcome for your lecture.
Okay, thank you very much first for those very kind words, Helmut. Nobody has said that in a long time, so it was good to hear that. But also, my personal thanks to my good friend Haru for his kind invitation to this symposium. And Haru, we've always been impressed with how you've taken the field of endoscopy and also now education with Tokyolive. So it's definitely my pleasure and honor to do that. So if you can see my screen, I will go ahead and get started with my lecture, which is on the future of artificial intelligence in endoscopy and how do I see it go on. What we've already heard from all the experts so far in this session is looking at different types of artificial intelligence, and specifically when it comes to endoscopy, which is a visual type of AI. But I think I'd just like to inform and just remind our audience that this is just, one of the types of AI, that was going to impact endoscopy. We have text-related AI, we have interactive, functional artificial intelligence, and analytical artificial intelligence as well. And so all of this combined, I think, is going to have a major impact in the field of endoscopy and gastroenterology. And what we talk about is just sort of what I call as the tip of the iceberg, because it's for disease recognition, pattern recognition, but all these other types of AI will also impact endoscopy in different ways. The other thing to remember is that we are quite behind when it comes to the field of medicine. Now, this is a summary on the left that you see is how digitally advanced is your industry. This was a question which was asked, and you can see on the left, number one is IT, of course, then comes media, then comes finance, insurance, etc. But if you look at healthcare, it's really at the bottom of the list. So we do need to have these kinds of meetings to discuss this, but also remember that we have a significant potential for improving, not just in endoscopy, but in healthcare in general. And I think that's important to do it. So once we talk about the future of AI, we've talked about, we've heard several lectures today about how to diagnose diseases through endoscopy. Drug discovery is another important thing. The key thing that I'll focus a few slides on is this multimodal approach in artificial intelligence, which will lead to personalized medicine. And then in endoscopy specifically are some of the challenges in implementation. How do you get AI in every endoscopy unit that can afford it or has the ability to do it? So in computer vision, we've already heard a number of different lectures about this. But when it comes to, for example, early gastric cancer, segmentation and leading to this kind of annotation, I think is extremely important. And this is just a video and images showing you that area of early gastric cancer, which we've already heard about. But then this will lead to further, improvements such as characterization, such as delineation of this lesion, and then the AI suggesting tools, whether this is something which should be removed by EMR or should it be removed by ESD, because it's a small lesion. So what are some of those things? So rather than asking Helmut or Haru for their opinion from another country, the AI can help you in suggesting what different types of tools could be used for this as well. So I think that's something important. We also need to recognize that different types of artificial intelligence exist. Narrow AI, in which it's specialized only in one task. A good example is the self-driving cars from Tesla. Okay, so this is very narrow. It's just helping you do that. Then is general AI, which is at the human level. And this is, of course, the mega computer, which is now available or has been produced, in which it's as good as human intelligence. And then, of course, will be super AI in the future, in which AI is perceived that it will be much smarter than humans, like the cyborg, which is depicted here. And this is probably where we are in the field of artificial intelligence in general. Now, if you look at AI in endoscopy, where are we in different types of decision making? This is where we are, level 0, which you could say, which is conventional endoscopy. Then you can go to level 1, which is endoscopic diagnosis with CAD-E and CAD-X. Level 2 is endotherapy automation, in which its endotherapy is initiated by the operator. Level 3, you can see that this is self-initiated by AI. Level 4, in which you can perceive in the future a self-driven scope with self-initiated therapy. And then, of course, would be full automation, which would be the super AI, in which an endoscopist is not required. Hopefully, we'll never reach that situation. I think this is just a concept, but again, telling you that right now we are just at level 1, and the future is level 2 and 3 for sure, which will be coming down as we move into the future. What's this concept of multimodal approach? I think this is important for us to understand, which is also part of future of AI in endoscopy. Let's use inflammatory bowel disease as the use case here during endoscopy. You can see that you have the CADX now, which can tell you whether this is a Mayo score 0, which is on the top, Mayo score 1 in the middle, and then Mayo score 2 or 3, which is at the bottom. So this is conventional, right? I mean, this is what we think is there right now, and it's available. The second is now tying in AI to response to therapy. So for example, again, using IBD as the use case, you can look and see the baseline characteristics and see what are the baseline variables which are important, and then look at the variables at 8 weeks. Putting the baseline and the 8-week characteristics together with the help of machine learning, it can help predict who is going to respond to therapy with a biologic agent. So you have this information now. The next piece of information you can get from digital health, which is from the electronic health record system, using natural language processing. For example, you have the texts which are generated from the office notes and from the nursing updates. Then you have the patient using their smart phones telling us how good they are doing, as well as their own notes that they're taking. So what this does is that it takes this kind of unstructured data into structured data, and it's able to then do whether it's a disease description, a medication, or a modifier, or a status. So for example, if the patient reports more urgency and frequency of diarrhea, then that's a disease description. And this can then get fed into different structured data, which can be pooled together. So multimodal data is not taking just the endoscopy image and saying that this is Mayo grade 2, inflammation, but it takes into account whether the patient will respond to the biologic. It will take this unstructured data, put it all together, and that's how I think we will take care of patients in the future with the help of artificial intelligence. The same thing for that video I showed for gastric cancer. That's just one data point on endoscopy. But how about the patient's age, the patient's family history of gastric cancer, the patient, whether they will respond to chemotherapy or not? All that will be taken together, and that's how I think we will be doing it. So that's multimodal for the future. The next challenge right now, I feel, is the implementation of artificial intelligence in our endoscopy units. And there is struggle, and we will continue to face struggle because of a number of these things that I'll be listing. Here are barriers to implementation of artificial intelligence. Algorithmic limitations as to how good is your algorithm. Data access, which is a limitation. There are a number of regulatory barriers. Japan has its own barriers as compared to EU, as compared to the US FDA. So those are all barriers. And then, of course, there can be incentives which may be misaligned. We want to use it for improving patient care, but then, of course, there's always the financial incentive, which is there as well. So we have to make sure that there is a need for complementary innovation and support in order for us to overcome several of these barriers. Then the barrier from the side of the physician. This is all a black box, and do we trust this black box? Are these algorithms generalizable or not? And so there's this whole concept about trust. So the system cannot do what it is not trained for. So I think industry needs to be more transparent when it comes to this about, what was this based on when you see these different CAD-E and CADX devices which are out there. And all these CNNs are designed by humans, but they developed themselves over time. And that again is a huge trust factor as far as endoscopists are concerned when they see artificial intelligence. So this is also a barrier for implementation as we move forward in this field. Will we get reimbursed for artificial intelligence? Who will pay for it? This is an example of contact CT in the US, which is paid. So once you have a large vessel occlusion for a stroke that the patient is having, this is the image. The radiologist looks at it. He looks and then makes an alert. A HIPAA compliant message is then sent to the referring physician, to the neurologist, to the ER. The stroke team is activated so that the patient can go and get to the stroke center and can get thrombolytics. This is called contact CT, and this entire process is now reimbursed by insurance companies in the US. Will we see something like this for endoscopy as well? Well, time will tell. It's not that very simple or clear that will happen. But we need to have more data like this as to what's the cost effectiveness of AI. And this is a paper which was published by, Cesare Hassan, Yuichi, Helmut, and the group to look at this cost effectiveness of AI for screening colonoscopy for CAD-E and CAD-X. And this is looking at colorectal cancer incidence and mortality with and without artificial intelligence. And you can see that in this Markov model, both the incidence and mortality is positively impacted by artificial intelligence. So you can have a reduction of 5% in incidence and 3% reduction in mortality by increasing recognition of polyps. And the cost per person saved was a reduction of $57. But again, you can see that there are a lot of assumptions which go into this model in order to look at this. The cost initially increases due to more polypectomies and decreases, but then again, it decreases due to an increased adenoma detection rate, which leads to cancer prevention in the long run. So at least preliminary studies show that AI, at least for colonoscopy, may be a cost-effective tool. And these are the data which may help, CMS as well as other insurance agencies globally to pay for artificial intelligence and reimburse for this situation. So at the end, what we are left with is we need to create responsible artificial intelligence for endoscopy in the future if we are going to have a major impact in this field. The algorithms that we use should be reproducible. They should be secure. I've not touched on data security, but again, in the short time, it's difficult to do that, but it's very important to recognize we need that the data is secure. It's human-centric, so that we need to have a human-in-the-loop type of artificial intelligence. They should be unbiased in their approach. We should be able to justify to our patients why we are using it, rather than just because we think it's cool and because this is the wave of the future. No, we should be able to justify its use. The models should be explainable. People should start trusting that black box concept, and we need to know this explainability which goes with that. And finally, over time, we should be able to monitor the artificial intelligence and make tweaks as and when required for us to help into the future. So with that, Helmut and Haru, thank you all for inviting me for this wonderful symposium. And my congratulations, Haru, to you and to your team of Tokyolive for yet another very successful Tokyolive. Thank you.
Thank you, Pratik, for this exciting lecture and the view beyond what is the potential of AI, not only for endoscopy, but also in healthcare and so on. So I think the future will show us there is a lot of potential. You showed it from the industry, from other disciplines like radiology, and for sure the benefit for endoscopy will come and is almost here. Yeah.
So thank you very much. And I would like conduct the discussion. And first, I'd like ask the Professor Fan. So so you nicely, clearly presented the current situation of the gastric cancer in the U.S. And as we realize that if you install the AI, implement the AI in the US, so what effect, positive effect may happen in the US?
Well, as you know, the examination of the stomach is very difficult. And the Japanese really have perfected the classification or the identification of lesions and how careful one needs to examine the stomach. The United States is not as adept, and we're not trained really to do gastric cancer examinations for the gastric mucosa. We often just kind of do a quick look. We'll take some random biopsies and get out of there. So I think that AI has enormous potential and really will accelerate the adoption of gastric cancer screening, because it will really help to identify lesions. It will help to train physicians to see these lesions. But more importantly, I think in the short term, it will really help to target our biopsies. I mean, the U.S. we're not going to get away from biopsies. There's no way that we're going to just do endoscopic evaluation and characterize these things. It's too ingrained in the U.S. system that we need tissue in order to do some type of advanced procedure or resection. So what I think AI will do in the immediate future is really help target our biopsies, and then from there we will really learn to do high quality endoscopic examinations. But the bottom line is it will rapidly increase our ability to detect early lesions and hopefully impact gastric cancer outcomes.
Yeah, thank you so much. So yeah, actually AI, so medical system, so this AI diagnosis works well to detect the early stage gastric cancer. So yeah, thank you so much for your great talk again.
So I have a question to Dr. Markov regarding the cost effectiveness in this model you presented. So my first question is, was endoscopy treatment included in this model? Because we know there is a couple of years ago there was a similar study published, but the gastric cancer were treated by surgery. So my question is, were endoscopic resection included in this model? And my next question is, can AI probably also reduce the costs and so be cost effective for the future treatment of gastric cancer screening?
Oh, so that's regarding the Markov model. Yeah, so it was based on endoscopic resection. So there was a cost savings. So they did not go for full gastric resection, whereas if the comparator group would be diagnosed at a late stage and then would go on and would have all the costs associated with a large gastric resection. What I would say with AI is it theoretically should further improve the cost effectiveness of this, because you would further detect more early gastric cancers than you would be shunting away any of those patients going for a large surgical resection, which we all know that advanced cancers costs a lot more. So if you could prevent any patient going down the advanced cancer pathway, you're going to save money. So I think, we see these types of things in like closed systems. So there's a system here, Kaiser Permanente, who they're self-insured, and they see the value in detecting early cancers and then treating with endoscopic submucosal dissection, because they know that it saves money down the road. So they're ahead of the curve when it comes to something like that. But I think that eventually we'll be moving in that direction.
Do you expect a difference of sensitivity, specificity between cancer in Europe and between Asia, or is it we do this trial, you will do this trial to show whether there is a difference, but what is your impression? What is your feeling? Will there a difference or not for the AI system?
Thank you for your question. And actually, to tell the truth, we have no data testing in EU population, but I see Portugal and Italian data. The gastric cancer in Italy or Portugal resembles Japanese gastric cancer. So we hope we are highly confident that our system can be used also in EU populations. But we have to check up. So
I think we all expect it, but we have to prove, right?
Yeah.
Dr. Ebigubo. So I was so impressed your great results of Barrett detection by AI diagnosis. So, of course, in Europe, you have lots of experience of Barrett cancer. So even though the AI works very well, so detecting the high-grade dysplasia, including high-grade dysplasia. So, you have already a very well-established system. But my question is sometimes the pathological diagnosis, I'm talking about the early stage, so high grade and the moderate grade or the low grade. In such a case, pathological diagnosis it's sometimes controversial. So I think we hope that the AI diagnosis make a standard of the diagnosis, including a pathological diagnosis. So do you have some comment on that?
Yes, thank you very much, Professor. That's a very important comment, because as we all know, even pathologists find it difficult tackling the differentiation between, for example, inflammation and dysplasia, or distinguishing between low-grade dysplasia and inflammation. What we do in the training of our system, of course, is we try as much as possible to have our gold standard of reference certified by 2 pathologists. So before we accept a diagnosis of a lesion and feed it into the system, we need to make sure that the pathologists are certain of their diagnosis. And the most difficult area, of course, is low-grade dysplasia, where we, and also the guidelines tell us that we need 2 pathologists, a reference pathologist as well. But at the moment, we cannot yet distinguish between low-grade dysplasia and high-grade dysplasia. The AI system distinguishes between benign lesions and high-grade dysplasia or mucosal cancer.
Severity or confidence ratio, that is maybe very helpful to us or patients as well. So thank you so much, Dr. Ebigubo Sensei. So.
First of all, thank you everybody for your excellent contributions. I think it was a complete exciting session on AI and screening in upper GI lesions. So for the AI system in the stomach, I'm wondering in the future whether to differentiate all the expanded guideline criteria. As we know, we can treat also some expanded criteria. Maybe in the future, AI can guide us a bit more. Which is there a difference in this expanded criteria as well? I thought that AI will not only have the chance to pick up lesions, to differentiate lesions, but also to stage lesions. So we expect for the Barrett, but also for the gastric cancer, really a support how we can treat these lesions. And I was really excited about developments like the microRNA in gastric cancer for screening as well. I'm wondering whether this technology is also helpful in surveillance of patients who have been treated. So I think for the future, upper GI, as you showed your data, the gastric cancer is still much more frequent in US, but also in Europe and Germany. We do have much more gastric cancers and Barrett cancer, but everybody talks about Barrett cancer. Nevertheless, I think this session showed us that AI in the future will influence how to screen, how to perform surveillance, and how to treat these pre-malignant lesions. And I hope we can save lives, and we can save lives, as you have shown, much more effective, cost effectiveness, because this is also an issue. And maybe also in the future regarding green endoscopy, perhaps we can save also some waste for the future, and do for our health a lot more than just only doing endoscopy, but also saving lives and saving our environment. So thank you, everybody. And now I think once again, Haru, it was a pleasure to be part of this exciting session, to be part of Tokyolive, which is one of the outstanding web meetings worldwide with thousands of participants. Congratulations. And I hope you will continue this wonderful meeting in the next couple of years. Thank you.